So good afternoon, everybody. It is my huge pleasure to introduce Dr. Paul Turner, who you can see his affiliations there, but Paul heads up the food allergy group, the research group at Imperial College, and is a leading expert, has been very much involved in the COVID epidemic and trying to help with all of the allergic responses to the vaccines that have arisen. And it's really good of you, Paul, to take out this time to give us some benefit of your wisdom in terms of wardrobe malfunction, drug allergy 101. I'm really excited to learn what's in your wardrobe. All the best. Thanks.
Thanks, Gareth. And there'll be a prize for someone when we can go back to the pubs if someone can work out where the wardrobe malfunction theme comes from. So we've only got a small group on live, so please do feel free to contribute. There are some sort of slides, and if you're feeling brave enough, and I know some of you will definitely be brave enough, then please do chip in and we'll try and make it as interactive as possible. So in terms of allergy, the crucial things that we need to think about is that allergy is a hypersensitivity reaction, and it's an immune-mediated hypersensitivity reaction. And in order for that to happen, there have to be two stages. The first stage of sensitization, and this is where someone is initially exposed to something so that they can then develop antibodies and become allergic, or alternatively, if it's a cellular mediated system involving T cells, for example, the T cells can develop that sensitization through systems that we don't fully yet quite understand, but presumably have something to do with the T cell receptor. And then it's only with subsequent exposures that one can experience clinical reactivity. And so one of the big conundrums about drug allergy is how someone can have an apparent allergic reaction the first time they are given a drug. Presumably, they must have been exposed to it earlier on in life, perhaps not through a medication, perhaps in the food supply chain or something like that, or perhaps in utero, perhaps. Their mother was exposed to it. But it's a very common story that actually, unlike, for instance, with food allergy, where normally the first time people have an exposure, we know they've had exposure they've been fine with, and it's only later on they present with allergic symptoms. For drug allergy, it's the opposite, and usually it's that happens in children at the first obvious exposure in many, many cases. So it's common. If we look at hospital admissions, roughly 1 in 10 kids will experience an adverse drug reaction. Now, that's not the same as an allergic reaction. And this is one of the problems that we have, that people develop some adverse reaction, it gets labeled as allergy, and then effectively they're then labeled for life. If one goes to children's outpatients clinics, 1.5% or so will say, yes, I'm allergic to penicillin or something like that, even though the vast majority actually probably aren't. We have much more limited data on these things known as severe cutaneous reactions, or SCAR, severe cutaneous adverse reactions. And we'll talk a little bit about those. And the Kids Hospital in Toronto reports an incidence of severe cutaneous reactions at around 1 per 10,000 admissions. And that number might sound surprising, it might sound low, but actually to me it's surprisingly high. These are kids who have life-threatening cutaneous allergic reactions, often requiring intensive care. And that's actually 1 in 10,000, which strikes me as being much higher than I would have thought it should have been, but it's probably true. So let's think about some cases to help guide us in this Allergy 101. So my first case is a 12-year-old girl who has presented with a group A streptococcal pharyngitis. The organism is sensitive to penicillin, and we want to treat that girl with penicillin. But somewhere in the story, it says, yes, I'm allergic to amoxil, or the mum says she's allergic to amoxil. She had a rash when she was 3 years of age. So what are we going to do? What information do we need to know in order to try and tease out whether we can go ahead and give this child penicillin or not? Is anyone brave enough to comment? And by all means,
I'm not going to be commenting, Paul, but if anybody wants to say anything.
So we've got So Costas wants more history. Absolutely. I think it's going to be a little bit like pulling worms out of a block of wood or something. This is what I want to know. So why was this child prescribed amoxil in the first place? And that's important because we know younger children are often prescribed antibiotics for viral infections, or almost certainly viral infections. And so we then are in a situation where we need to tease out if they got a rash. Is a rash because of the virus? Did they have a viral exanthem and that's been misinterpreted as a drug reaction? Or actually, did they have, is there no sense of that, of a potential other cause for whatever symptoms that have been attributed to the antibiotic, and therefore maybe it is a true allergic reaction? What actually happened? How many doses did they take before reaction? Was it, you know, a week on down the line that they had a very non-specific rash that came on hours after the reaction? Or was this literally, you know, day one, within 10 minutes of the antibiotic, they developed urticaria? How was that drug administered matters. What was the timing from a dose to then having the reaction? What symptoms did they experience? Was it anaphylaxis, cardiovascular, respiratory symptoms? And what's happened since? Because the number of times someone's labeled penicillin allergy, and because they had a reaction to amoxicillin in infancy, and then actually they've had 2 or 3 courses of penicillin V since, clearly they're not penicillin allergic. It might be amoxicillin allergic, which would be unusual, but it's possible, but they're certainly not penicillin allergic because they've had it since. Or the other way around, they've had penicillin, they've been labeled as penicillin allergy, but then someone's prescribed them amoxicillin, completely fine, in which case they're definitely not penicillin allergic. So it's really important to ask these very simple questions. And we often accept an antibiotic drug allergy as being, well, must be true. But actually, 80 to 90% of patients with this sort of story of penicillin allergy have negative skin tests and go on to tolerate penicillins when we then give it to them. And there are real significant consequences of this that have been now widely published in the general literature as well as the specialist allergy literature. These patients get inappropriately labeled, associated with increased health costs. We end up automatically using more expensive alternative agents, which restricts the choice of antibiotics we can use. And that's a real concern now with antimicrobial resistance. And then now some very widely well-established protocols for delabeling children as soon as we can as being drug allergic, because otherwise they end up being labeled for life. And one of the really interesting things that came out a couple of years ago in a audit called NAP6, which was an audit of perioperative anaphylaxis in the country run through the Association of Anaesthetists, was that even when you delabel at formal challenge and state that in a patient's medical notes, anaesthetists are still scared to use those drugs perioperatively. And so you actually end up being labeled even once you've been delabeled. And there's some very interesting work happening amongst anaesthetic circles at the moment to try and understand that better. So when we do clear someone of a drug allergy, we can actually establish and get it wiped from their record altogether. And anaesthetists are no longer concerned about the history. So what do we find out in this case of this 3-year-old girl? Well, it's the first time she was prescribed antibiotic, and it was given for earache by her GP. The reaction happened following the second dose. It was an oral antibiotic, and she developed patchy urticaria within 30 minutes. And helpfully, the family have actually got some photos. And it's really handy. Always ask, did you take any photos at the time? Because now that everyone, or not everyone, but so many people have mobile phones with camera facilities, it really is a really helpful way of seeing what happens. And if you're on the acute service on the wards and someone has a reaction, make sure the family take a photo of it, because if they ever come to see someone like me, it will be so much easier. The urticaria resolved the next day, and she's never had any penicillin products since. So what do we do now? Do we give her amoxicillin again? Do we give her a non-beta-lactam alternative? Or do we give her something else? And by all means, put in the chat if you've got any ideas, but I might just move on just in case people leave me empty-handed. So in this case, what happened is that this girl got given erythromycin and referred to someone like me for evaluation of possible drug allergy. And we felt that there could be an Ig-mediated reaction, so an immediate type allergic reaction, because she had a generalized reaction, although it certainly wasn't anaphylaxis. She had a systemic skin reaction, and it came on quite quickly within 20 to 30 minutes of exposure. And so there's a question, what do we tell her to do? And what do we tell the family to do? Does she need to avoid just amoxicillin? Or is she penicillin allergic? And we need to tell her to avoid penicillins. And what do we do about cephalosporins? Because they are sort of go-to medicine. If someone is really acutely unwell in accident and emergency, they'll generally end up with a cephalosporin, but that's a penicillin. It's got the beta-lactam ring. So what do we do in terms of that? And so I guess it's helpful to think about the classification of adverse drug reactions involving the immune system, so allergy. The first type is pseudo-allergic reactions. So this is a sort of a gray zone area where it looks like an allergic reaction, it smells like an allergic reaction, but actually the symptoms result due to non-specific direct activation of cells such as mast cells. Mast cells are what are often labeled allergy cells that reside in skin and in other tissues such as the gut, lungs, and so on. And the examples that, probably the most well-known two examples that we have are, first of all, Vancomycin red man syndrome. Anyone who's worked on the hemonc wards will know all about red man syndrome. And then secondly, for those who've worked on post-operative patients, opiate-induced pruritus. So following operations and so on, where patients are given opiates such as morphine, they do get itchy. And that's due to direct activation through opiate receptors on mast cells, causing mast cell degranulation of histamine and other fun things causing itch. But that's not allergy. It doesn't involve an Ig-mediated receptor, and it shouldn't cause a sort of inflammatory cascade. That worst case scenario can be fatal. The other sort of common story, which is less common actually now, probably for the trainees on the call, as opposed to when I was a trainee, was amoxicillin-induced pseudo-allergic rash. So when you give people with EBV, amoxicillin or ampicillin because of their pharyngitis, which obviously we shouldn't do because it's EBV induced, but used to happen a lot in general practice. There seems to be some sort of interaction between the immune system, EBV modulation of the immune system, and amoxicillin, which would cause this classical sort of maculopapular rash to develop if the patients were prescribed amoxicillin. Those are all pseudo-allergic and are in contrast to type 1, 2, 3, and 4 allergic reactions. You might remember this from medical school, Gels and Coombs classification. Type 1 involves IgE-mediated activation of mast cells, so this is the same as peanut allergy and so on. And the most common example, for instance, to IgE are penicillins. And interestingly, as I said before, 1 in 3 patients with demonstrated penicillin allergy have no record of previous exposure. So they must be exposed to penicillins through some other route, such as the food chain or something like that. Type 2 hypersensitivity involves the activation of complement, and the sort of the RC-PaeCH membership exam example there is quinine-induced thrombocytopenia. Type 3 is due to immune complex formation. So this is where there's an interaction between antibodies and part of the drug causing immune complex formation. So you've got antigen and antibody complexes circulating the body, which clogs up small vessels and so on. And that can cause things such as serum sickness. The most well-known example of that is C-Chlor, which is not a drug that I think really sort of took off in the UK. It was used quite a lot where I trained in Australia. It was certainly used to be used quite a lot as well in the States. And when we realized, or when pediatricians realized that it was associated with a relatively high rate of type 3 reactions, it went out of favor in terms of other oral cephalosporins. We've always tended to use cefalexin in the UK. I think, Gareth, nod if I'm on the right tracks here. I've never come across C-Chlor in the UK in my training, but obviously my training sort of started 20 years ago. And so it might have maybe been used prior to that. The other example, the membership exams often want on interstitial nephritis, which rarely is supported to penicillins. And then finally, we've got type 4 T cell mediated reactions, but not maybe just T cells. To be honest, these are sort of reactions that aren't 1, 2, or 3. We label it as T cells. We don't always know that they're definitely T cell mediated. And examples of those are cutaneous hypersensitivity reactions, for instance, to antihistamines. It's quite ironic that we will often treat people with allergies with antihistamines, but they are also relatively not common, but not uncommon cause of cutaneous hypersensitive symptoms. And I'm allergic to 1 or 2 antihistamines through a type 4 mechanism. And of late, the Jelen-Coombs system has been modulated a little bit. So we now have this sort of type 5, although you're not meant to call it type 5, which is drug-induced autoimmune adverse reactions, which are probably T cell mediated, but associated with genetic risk factors as well. And an example of that, very uncommon in children, slightly less uncommon in adults, is drug-induced lupus. An easier way, though, of classifying things in terms of clinicians is actually just this. Is it immediate type reaction, IG mediated, or not? And that's important because if it's immediate, there's a risk of anaphylaxis. Whereas if it's not immediate, there's not a risk of anaphylaxis, and we're therefore either talking about relatively dull and boring maculopapular eruptions. When I say dull and boring, they're dull and boring because they're not life-threatening, or funny, odd reactions known as idiosyncratic reactions, at which one extreme end is the severe cutaneous adverse reactions or scar reactions, which can be severely life-threatening. And there are some useful pointers towards one or the other. For IG-mediated, typically symptoms come on in under an hour, causes the itchy sort of rash as a prominent feature. We don't generally see skin desquamation. There's no mucocutaneous involvement, so you don't see conjunctivitis or anything like that, or reddening or involvement of the lips. There can be anaphylaxis. Take the trigger away, things stop, and you don't usually see any eosinophilia. And this is in contrast to delayed, mostly T-cell mediated reactions, which typically come on hours later, often are associated with an exanthema, but may not be itchy. Often can then result in subsequent desquamation, so peeling of the skin. Often the mucous membranes may be involved, but not always. Can cause multi-system involvement, and when it causes multi-system involvement, that is often multi-system organ failure, and you're looking at an ICU admission. Delayed resolution, despite stopping the trigger, things carry on for days and even weeks while things get back together. And finally, is often associated with eosinophilia or neutrophilia. So one really useful, important test to do if you've got a non-immediate type drug reaction is do a full blood count and look at the eosinophils. Now, penicillin allergy is reportedly very common. Up to 1 in 10 people will report I'm allergic to penicillin if you ask them. And it isn't always just immediate. There are late onset penicillin reactions where we classically say the symptoms start 72 hours later, but actually we got a bit of a gray zone. What happens if you're between couple of hours and 3 days later? And it's not quite clear if this is sort of delayed immediate or rapid onset late, and it gets a bit confusing. I won't go there because it confuses me. And often we have sort of idiopathic reactions where we're not quite sure what the underlying mechanism is. And just to remind you of what IgE does in terms of mast cells. So at the top, you've actually got the mast cell itself, and stuck to the mast cell in green are these high affinity IgE receptors. And then the Ig antibody pops along, is stuck to these high affinity IgE receptors. Your red squiggle is the antigen. In this case, it might be a penicillin. That binds to 2Ig through different IgE receptors through a process called cross-linking, and it's that stimulates mast cell degranulation. And you can see in the top left, all those sort of dark grey black granules, they've all disappeared because they've all been sort of spat out by the mast cell. That's a degranulated mast cell, you can see top right. And it causes tachycardia such as this, generalized reactions, and very occasionally anaphylaxis. Anaphylaxis isn't particularly common to penicillins, interestingly, and it's mostly seen in adults rather than children, at least to a penicillin itself. Late type reactions I've sort of mentioned is caused by the formation of complexes between a penicillin or other drug and the antibody. And there's a non-IgE mediated antibody reaction. And you can see that there's typically a lag of up to a week or two while we're getting this complex formation. And it's only then that symptoms then present with fever, vasculitic type symptoms, arthritis, and nephritis. Late reactions are thought to involve T cell activation and can cause sort of this bullous type picture. And then we get these idiopathic reactions where just a non-specific maculopapular rashes, which are the vast majority of what kids seem to get. And they're not uncommon. So roughly 1 to 4% of patients given a penicillin will get this maculopapular idiopathic reaction. There's an increased risk if it's amoxicillin associated with EBV is the most well-known one, but also CMV and ALL. There are a few reported cases of kids and adults with undiagnosed ALL given antibiotics, getting this sort of rash, and it's seen to be linked to this sort of underlying sort of immune priming by the ALL. If the history is typical of only a maculopapular rash, a non-itchy rash, so there are no IgE features to suggest an IgE mechanism, then it's probably safe to give penicillin again, particularly in children. Generally, we do it in hospital, doesn't need to be booked into a challenge clinic or anything like that. And less than 1 in 10 have a recurrence of these idiopathic reactions. And it can be really helpful to do this and to document it that actually there is no, there's no sign of demonstrated reproducibility to this drug reaction. We can clear them. The bit where you might need someone like me is to then sort of unpick, well, actually there are IgE symptoms. And so maybe we think this is a real reaction. And are we concerned about cross-reactivity between either in the sort of middle, the sort of bright red circle, the beta-lactam ring, or alternatively, the side chain, a bit that's stuck onto this beta-lactam ring? And majority of people allergic to penicillins are actually not allergic to the beta-lactam, but they're allergic to the side chain. And these side chains can be found not just on penicillin, but also on other beta-lactams, such as cephalosporins and so on. And that's what causes cross-reactivity. And that's where you then need someone like me to come along and say, well, let's do some skin testing to try and work out what drugs are safe or aren't safe. And skin testing is very useful for type 1 reactions, IgE reactions. Less useful, but increasingly useful, if that makes sense, for late type reactions. And I'll explain why in a few slides' time. And so what we do is, if let's say we've got a history of penicillin allergy, we will do skin testing. We'll often do skin prick testing first, which is where we just scratch the skin, as you can see in sort of picture 1 here. That's pretty useless. We just do it to ease the kid in, make them feel at home, that we're not going to sort of torture them. But the main test we do is actually intradermal testing, which is painful. And we have to tell people that it is going to hurt. I've never got caught out by telling someone it's going to hurt and then them going, God, it hurt more than I thought you told me to. Whereas I have seen colleagues caught out by saying it doesn't really hurt, and then actually it hurts like merry hell. And so it's really important with children that we're very upfront and honest, and likewise that we try and minimize and rationalize how many intradermals we do in order to really sort of not overdo it. So whereas in adults we might do 10 or 20 intradermals in one go, in kids we'll do 2 or 3 and then wait and then decide to do another couple if we need to. And so there's sort of a structure to how we sort of investigate. And eventually we want to do a challenge in most cases. And the intradermal is to tell us whether it's safe to go ahead or whether we need to have lots of safety netting in place. It depends on how good the history is. Now with penicillin, something that sometimes comes up in membership exams is this concept of major and minor determinants. And this is because you don't react to the penicillin. Penicillin itself is not immunogenic. However, it becomes immunogenic when it binds to plasma proteins, such as albumin. And so around 3/4 or so react to penicillin bound to a protein. You have to be bound to the protein in order for the IgE to recognize it. There are around 1 in 4 people with penicillin allergy, however, who are allergic to the minor determinants. That's why it's called minor, because only 25% or so of people are allergic in this way, where it's actually the penicillin metabolites, which then form disulfide bonds with various proteins, usually cysteine, and it's the IgE recognizing that complex, or the penicillin metabolite bound to cysteine, as opposed to the penicillin itself. And if your skin testing to both of these is negative, you are very unlikely to be allergic when we then give you the penicillin. Now, I can just see on the chat.
Yeah, can you just answer Peter's question possibly?
Yes, I'll have a look. I'm just seeing now. So Costas has just flagged up about blood testing. No criticism, we don't call it RAS testing anymore officially, because that we no longer use that methodology. It's just that old people, particularly in allergy, we don't like new things. And so we tend to call things RAS testing, even though they're actually not. This is now known as specific IgE testing. Again, don't get caught out in membership exams. So we don't do blood testing because it's pretty much a waste of time. Certainly for penicillins. And then Peter's asked, is it possible for idiopathic penicillin reactions to occur in a child, but then not to occur when we then expose them in a challenge clinic? So we then clear them, but then happen later. And the answer is, I guess, yes. If you think about the amoxicillin and EBV interaction, it's quite possible that someone will have an idiopathic reaction due to underlying, they've got EBV or acute CMV on board. And then when we challenge them, nothing happens because they're well. And then were they to get sort of EBV exposure reactivation later on, and again get given amoxicillin, they can react again. But then it's not an allergic reaction. And what we're worried about is an allergic reaction, which might be life-threatening. So in that sort of story, I would go, well, it's, it sounds very much like this idiopathic, maybe partly immune activated due to some viral thing going on. And therefore we can be a bit more relaxed. Although in practice, I would then still give them a test dose to reconfirm the fact that they're not allergic, because otherwise they're always going to give that story, and there'll always be a clinician somewhere who goes, oh, maybe you're allergic after all. If that answers that question. So cross-reactivity with cephalosporins is usually due to the side chain rather than the beta-lactam. And often, if you look in the literature, we were sort of told that up to 15% of people with penicillin allergy would be allergic to cephalosporins. But actually, as we've looked more closely at this as a community, particularly with the more recent second and now third generation cephalosporins, the rate of cross-reactivity is much less. And this is because the side chains on second, third generation cephalosporins are a lot more different from sort of the amoxyl side chain that is found on a lot of first generation cephalosporins. And that is probably why actually the risk of cross-reactivity is much less than we used to think. And you can see here that we now sort of turn around and say that the cross-reactivity risk is less than 1% if it's a second, third generation cephalosporin, but probably a 1 in 20 risk if the person has positive skin testing to a penicillin. And it can work the other way around. So you can be allergic to cephalosporins, and then that, as a result, can be cross-reactive to certain penicillins too. Just bear with me. I'm the only person in the house, so that's probably an Amazon man. So in terms of how to investigate, I've got the slide up here. So as you can see here, what you want to do initially is think, okay, I'm querying penicillin allergy. I want to give them a cephalosporin. So this would be a typical sort of scenario of a patient coming to A&E, they're acutely unwell, and you want to give them, start them on a second or third generation cephalosporin. So if they're not massively acutely unwell, you might consider testing first, but clearly that's inappropriate in the acute setting. So then your options are, if the previous reaction to penicillin was not anaphylaxis, it may well be reasonable to give them the cephalosporin given the circumstances and the risk benefit. But note there's still potential to react. And cephalosporin anaphylaxis is rare, but it's not unheard of. It's not usually fatal, and therefore I think this would be reasonable if the patient can be observed in a safe area, and presumably if they're acutely unwell, they're not going to be discharged and ambulated, they're going to be kept in the hospital. If, on the other hand, you're thinking, well, maybe we want to at-home ambulate and we need to get them out of hospital very quickly for whatever circumstance, then you might want to consider giving them an alternative. And then there should be guidelines, certainly in my hospital, there are guidelines in terms of how to choose those alternatives, not just an alternative that is safe given the allergic history, but also an alternative that's appropriate to treat the infection you suspect to be causing that child to be unwell. Remember as well that meropenem is also a beta-lactam. And so if you are penicillin allergic and you have demonstrated allergy to the beta-lactam rather than a side chain, meropenem will be a problem. And again, this is a membership question that often comes up. However, the cross-reactivity is pretty low, less than 1%. And again, there's no obvious consensus on whether one would do skin testing first, or if acutely unwell, actually you're going to go ahead and give meropenem regardless, but give it under observation. So our second case here, 15-year-old boy with infective endocarditis. He is known to have penicillin allergy to penicillin itself, not to amoxicillin or anything like that. He developed widespread urticaria and lip angioedema within 30 minutes of a dose around 5 years ago when he was given penicillin to treat pneumonia. And he is already on IV vancomycin. He is not getting better. And the advice from the micro ID team is we need to use penicillin. What do? So you phone someone like me, and I go, ooh, and then I come along because I've got nothing better to do with my life and I'm not sorting out COVID allergic reactions or anything like that. And I do an intradermal, which is 6 millimeters to penicillin, which is confirmatory that he's very likely to be penicillin allergic. What now? Don't give up. Speak to someone like me. So we've got this wonderful thing for IgE allergy called desensitization, which is a bit of a faff when we do it for allergic rhinitis, for hay fever, or alternatively for food allergy. But for some reason, which we don't really understand, works beautifully well and is very safe and relatively straightforward when it comes to drug allergy. And it's very similar to what we do for bee venom desensitization. We basically start low, give frequent increasing amounts, and within a day or two, and you can be desensitized. And actually, we can even do this within hours. So if you need to have someone who you need to start them in penicillin, they're penicillin allergic, or vancomycin, they're vanc allergic, we can actually desensitize them within a few hours of getting that call if the clinical need is there. And just as sort of an example of a typical desensitization program we use, anaphylaxis is pretty uncommon. I wouldn't recommend you do it without an allergist being available to supervise, but that can also happen remotely in an acute setting. And I've certainly done this a little bit by remote control at St. Mary's very safely. And if you look after children with CF, this won't be uncommon because there are some protocols available for this as well. The important thing is that if you then have a gap in the dosing, so let's say that you desensitize them for one admission, they come back a year or a month later, or even a week later, they may have lost their tolerance and therefore are clinically allergic again. So you need to desensitize them each time you give them the course of that antibiotic, in contrast to venom allergy and food allergy and so on. Now, the other interesting thing for penicillin allergy is that it's not uncommon for children to outgrow their penicillin allergy. So even where kids have gone through testing and we've demonstrated they have IgE-mediated allergy to penicillin, around 3/4 probably outgrow it within 10 years. And so even if you've been labeled penicillin allergic in early childhood, it's worthwhile being bumped back to allergy clinic in your teens to be re-evaluated because you may well have outgrown it. Okay, a third case. This is actually a real case that happened to me in a very well-known children's hospital around the corner from St. Mary's in central London. I'm not really sure what the name of it, but anyway, it's not an uncommon occurrence, and it's one of the reasons that actually SOPs were instituted in this hospital. I was called at night to see a 4-year-old kid on the hemonc wards with ALL on chemotherapy, had low platelets, and 20 minutes into being given a platelet transfusion became itchy, developed widespread urticaria, and was well, not compromised in any way, but when I had a listen, there was a good going expiratory wheeze there. And hopefully everyone listening to this is thinking, I've heard of this. This is called anaphylaxis, because we've got respiratory symptoms plus minus cardiovascular symptoms. And this will do for IgE mechanism. And because of the respiratory involvement, this is anaphylaxis. And therefore, what I'm going to be doing is giving the internationally agreed first-line treatment of anaphylaxis, which you are all going to mouth together with me, which is called adrenaline, intramuscular adrenaline. However, in lots of hospitals, this does not happen. And so I was called on to get out the Piriton, because of course that's the most common drug given on hemonc wards, apparently. And when I said, actually, I think we should be using IM adrenaline, this child is wheezy, let's stop the platelets, the local staff went, which strikes me as concerning. I do know it's got a lot better now, and this was 20 odd years ago. But it's amazing how many of these sort of reactions, if there's respiratory involvement, it's anaphylaxis, you've got to stop the infusion and give the IM adrenaline. Now, fortunately, drug allergy is very rarely fatal in children, as you can see in these data here. So these are data from the UK. The nice sort of pale blue line is food anaphylaxis. Darker blue is drugs, or what we called iatrogenic, so it includes contrast agents as well. And then you've got orange, we've got insect stings. And actually, probably due to polypharmacy, drug anaphylaxis becomes much more of a problem as you get older rather than in younger people. But this is what we should be doing if someone develops symptoms of anaphylaxis, so airway, breathing, or circulation symptoms following exposure to a possible allergen. In this case, we're talking about drug allergy. You stop the infusion. If it's an infusion-related medication, you make sure their posture is appropriate, i.e. they're lying down or sort of in a sitting position on a bed with the legs out in front of them. Do not stand them up, and they get an IM injection. And if you're not sure about that, or you want more information, click on the RC UK guideline and read up what's there for the new guideline that's coming out shortly. Antihistamines you can give, but not if they need adrenaline. By all means, give it to treat skin reactions, but they will not stop respiratory symptoms or cardiovascular symptoms. So it's adrenaline, adrenaline, and adrenaline. And forget about steroids. It takes about 4 to 6 hours for steroids to work. The patient will have died if they're having anaphylaxis of a high severity by the time the steroid starts working. They're at the right at the bottom of the list. This whole concept of Piriton and hydrocortisone and life will be okay, it's a load of rubbish, and we need to sort it out. All right, what about this case? A 5-year-old with a Courier line infection, charted for Vancomycin, and 20 minutes into the infusion gets this picture of, a bit of itch, this erythematous type rash. I've already shown you this by accident. It's red man syndrome. It can also result in angioedema and hypotension and dyspnea. So this is the direct mast cell activation. It's not an IgE-mediated process. So we're not stimulating this widespread immune cascade. But nonetheless, it is possible to have sufficient histamine release from mast cells to cause hypotension and dyspnea and breathing problems. And if you've got those, you have to treat with adrenaline, even though it's not anaphylaxis. You can't really, this is a gray zone case where you're not sure if it's allergy or if it's red man syndrome. The key thing that distinguishes red man syndrome from IgE mediated is essentially, if you slow the infusion down, it doesn't happen. And we don't really know why. And it would be reasonable in this sort of circumstance, maybe to pre-treat with antihistamines and hydrocortisone. And obviously, we're not going to change hemonc protocols in the next 100 years and stop that from happening. Certainly giving them a non-sedating antihistamine is reasonable. I'm not sure it should be Piriton though. And a hydrocortisone, well, maybe it helps because hydrocortisone has other actions apart from the typical sort of glucocorticoid receptor mediated processes. But it is quite common. And as I said, slowing the rate of infusion often helps. If you have someone with red man syndrome, stop the infusion, assess them, and if it's only a rash, consider giving them antihistamine cover and restarting at a slower rate under observation. If it's more than just a rash or skin symptoms, I think you need to speak to someone like me, to be quite honest. And don't make the trap of thinking, well, let's just switch them over to teicoplanin, it will all be fine. Because actually the cross-reactivity between vancomycin and teicoplanin is around 50–60%. And teicoplanin is one of the most common causes of severe perioperative anaphylaxis in the UK because we use so much of it. This is my last case, a 13-year-old female who presented to the neurology team with a 4-year history of recurrent migrainous headaches. And because of that long history, ended up getting an MRI scan, which showed she actually had an AV malformation. So she was commenced on lots and lots of nice prophylaxis, as you can see, and then went to theatre. And post-operative developed hypertension, a right pneumothorax, and was in quite a lot of pain. And it was during this post-operative course in ICU that she developed a fever with a blanching erythematous rash. And so, of course, fever and rash post-operative, we'll be thinking infection. And so various investigations were done. And as you can see, her transaminase enzymes were elevated, but not much. She was a little bit anemic, a little bit thrombocytopenic, had a normal white cell count, an elevated ESR, and an elevated CRP, and a low albumin. And she was commenced as a result of that with presumed infection on cefotaxime. And then the next day, her rash became purpuric. The cefotaxime and gabapentin were stopped because they were concerned this might be a drug reaction, and they carried on the dexphenytoin and propranolol. And you can see what her rash looked like here. She progressed, and this is what her hand looked like a couple of days later. She had refractory hypotension. She had pretty good going hepatitis with DIC, acute renal failure, ongoing fever. She became very edematous, and essentially the rash progressed to resemble purpura fulminans, as you can see in a picture of her hands here. And this is what her blood count did. This is why I say look at the full blood count. That one can see that all of a sudden in the red, we saw a spike in her eosinophils. And a diagnosis, we had sepsis, it could have been. We're thinking adrenal crisis. Could it be some sort of weird auto-inflammatory condition, in which case you'll be picking up the phone to me anyway, or a drug reaction? And what was interesting, if we look at her eosinophils, this was a sort of timeline that we started the propranolol phenytoin back here. And she was on this for a couple of months before her eosinophil count kicked off. This is where she had her surgery. And then because of the pneumothorax, she had a thoracoscopy. And this was the pattern that we saw. And the diagnosis that we came to was DRESS syndrome. So drug rash, eosinophilia, and systemic symptoms. And we felt the most common cause of this was the phenytoin. And typically with DRESS syndrome, it takes a week or two at least, sometimes longer, to cause the sort of eosinophil spike. And we're not quite sure what the precipitant was, that it happened in a post-operative period, whether it was a lack of stress cover prior to the thoracoscopy in a patient who'd been on high-dose steroids because of the AV malformation, or whether because a phenytoin dose had been increased for prophylactic reasons. But DRESS is one of these nasty T-cell reactions, the SCAR reactions that I mentioned to you before. And they're sort of common ones that you need to remember. So first of all, sort of Stevens-Johnson syndrome stroke toxic epidermal necrolysis, which is actually a spectrum, which often presents with often early fever, a painful rash, involves the mucocutaneous areas. You get vesicular involvement, blistering, detachment of the epidermis in TEN, For Stevens-Johnson's, it can appear, it tends to be more sort of cutaneous, sort of mucocutaneous. The sort of more mild forms of TEN can present just as erythema multiforme, without the sort of the more systemic involvements. And usually this comes on 7 to 14 days after first exposure. But if it's second exposure, you can have a more sort of accelerated onset. DRESS we'll go through a little bit more, which is what my patient had. And then in the middle is the more dull version. So AGEP, acute generalized exanthematous pustulosis, where you get widespread pustules associated with a neutrophilia rather than the eosinophilia. And fortunately, systemic symptoms are rare with this, but not unheard of. So these are the two you need to remember. And the management of DRESS essentially is stop the culprit, and we said it's going to be phenytoin. And for some reason, neurological antiepileptic medications are the most common causes of DRESS syndrome more than anything else. She was already on methylpred, so we threw in a bit of IVIG, which seems to work for everything. And actually, she did get better, fortunately, from her very significant multi-organ failure. She was in ICU for about 6 or 7 weeks. So there's significant morbidity and mortality. You can see what happens with IVIG, her eosinophil count really dropping down. She actually ended up having 2 doses because she's had a little bit of a rebound a day later, but IVIG does work. DRESS syndrome was coined by Bouquet in 96. Previously, it was just called a hypersensitivity reaction. It's a severe reaction. 1 in 10 people will die. That's why we need to be good at spotting it. And the onset's usually 2 to 6 weeks. The most common causes are aromatic anticonvulsants such as carbamazepine, phenytoin, phenobarbital, but also other non-aromatic anticonvulsants such as valproate. Other interesting things, allopurinol, sulfonamides, and occasionally some antibiotics as well. There are a couple of cases of cephalosporin-induced DRESS syndrome reported in the literature. There may be an association with previous HHV6 exposure and infection. There are also some HLA genotypes, that predispose you to DRESS syndrome. And so if, for example, in Australia, if you are Han Chinese and you need to be started on an anti-epileptic, it's now a routine to undergo HLA genotyping first to help inform the decision as to which anti-epileptic to be commenced on. More than 90% will have eosinophilia and atypical lymphocytosis. There'll be evidence of multi-organ failure, raised acute phase proteins, particularly procalcitonin, transient hypogamma, and sometimes we end up doing skin biopsies, but actually in the majority of DRESS cases, you do not need to do a skin biopsy, nor is it appropriate because they're very poor condition of their skin, and healing can be a problem there, and it can result in quite significant scarring. Some of us use the DRESS scoring system, which is, as you can see here, which can be helpful at least in the first instance, just to flag up whether this is DRESS or not. But I've certainly heard atypical DRESS where they haven't ticked all the boxes, and likewise cases that have ticked the boxes where you think it's probable or even definite, but actually the biopsy shows it's something else going on and not DRESS. That's what you see on skin biopsy, this intraepidermal eosinophilic infiltration and spongiosis, and the sort of pustule formation like you can see here underneath. And the most important thing is to stop the drug, particularly if it's a drug you're looking in someone on polypharmacy for the last sort of 3, 4, 5 weeks. It can be quite tricky there to spot which one it is, and you might need to stop everything. Pulse methylpred if it's severe. The IVIG, we tend to be much more liberal, like in pediatrics. The adults with DRESS, they're still quite scared of IVIG because there was a limited trial which was terminated early due to 1 patient getting a PE and 2 patients having very significant hypertension. But it was only 6 adult patients. And so in pediatrics, we'll tend to go with IVIG in the context of multi-organ failure and DRESS. And as I mentioned, phenytoin is the most common cause of this. Up to 19% develop rash with phenytoin, but very few patients who get that rash are actually DRESS-induced reactions. It may be more severe. There are case reports of mortality up to 40%, sorry, case series of mortality up to 40% in phenytoin-induced DRESS. It may be associated with more significant renal involvement. And what's quite interesting to me, there was a recent case at Great Ormond Street of DRESS, and the neurology team, most of them had not heard of DRESS syndrome, interestingly. And I wonder if it's much more commonly known about in Australia because of this association with Han Chinese, whereas actually in the UK, with our relatively less Han Chinese prevalent population, it's much less common than perhaps it is in other jurisdictions, other countries. So I'm going to stop there. I can see there's one more question from Alan. Redress syndrome. I mentioned that eosinophil count dropped after IVIG. Can you use this as a surrogate marker? I think one can do, but on the other hand, I'm just trying to get the slide back up again. So you can see, but it's just stopped sharing. So let me just try and share the screen again. So certainly you can do, and I do use the eosinophil count, but you have to use the global picture as well. In someone with ongoing elevated transaminases and diminished renal function and so on, even if the eosinophil count was going down, I'd still be tempted to continue pulse steroids and give a second dose of IVIG, because it's quite clear the inflammatory process can continue. So if everything's heading in the right direction, then yes, only give one dose. But actually, if the eosinophil count is going down, but you've got other indicators, increasing inflammatory markers and so on, you obviously have to worry about infection and treat that as if appropriate. But also, I think there is a case for giving IVIG. We do use IVIG in sepsis, so that's not inconsistent. And in some ways, you might prefer using IVIG than giving another dose of methylpred in someone where you think infection might be a major issue causing multi-organ failure and need for intensive care. So I hope that answers that question.
Yeah, Paul, can I just ask the dose of IVIG? Are you giving 2 grams per kilo? What are you giving?
So there's not much guidance there. I tend to use 1 gram per kilo and then repeat if someone's not really against heaven's door. But I think it would be very reasonable, you know, if the chips are against you and maybe it's a late diagnosis and you've got very severe renal impairment, you're looking at dialysis and all the rest of it, I personally don't see the harm in giving 2 per kilo, but we don't have any data to back up 1 or 2. I tend to use 1 in the first instance.
Okay, can I just add one other thing from an infectious disease point of view? HHV6 has come up a few times in your talk, and I think one of the important lessons for, you know, I keep telling our undergraduates that they need to be aware of the ubiquity of HHV6, that, you know, the classic presentation is in even younger kids, so under a year of age, with an febrile illness without focus, that 4 days or 5 days into the illness, you know, you get an immune response that develops a rash with which the fever lyses and the child is suddenly quite playful and well again. But if the child gets taken to the GP on day 2 of that febrile illness and is diagnosed with a little bit of a red ear and gets some amoxicillin, they then get labeled as allergic to penicillin. And you know, certainly I love the way that you talked about drilling into the history to find out exactly what the basis of that diagnosis of a penicillin allergy was. But it's not quite the same as the EBV and amoxicillin issue. It's part of the natural history of the disease, and helping people recognize that, I think. Have you got any comments?
I think you're probably right. I think EBV is the most well-known one where, you know, there seems to be this immune stimulation. I think probably what has happened, and I think I'm probably guilty of this, is that because HHV6 is implicated in certain sort of severe cutaneous adverse reactions, such as DRESS, I think you're probably spot on that it's sort of been extrapolated towards sort of the IgE idiopathic type thing, whereas actually, as you say, it's just part of the disease course and there's no sort of immune stimulation that then causes idiopathic reaction.
Yeah,
it's
exactly.
just the viral exanthem and pure coincidence. So thanks for clarifying that. I've certainly, you know, I'll try to remember it next time I give this talk.
Yeah, I mean, obviously the dress I think would be very unusual in such young children. And I'm talking the classic presentation of erythema subitum or exanthum subitum. Okay, this has been really great, Paul. Thank you very, very much. Are there any other last minute questions?
I was going to say, if anyone gets a link as to why this talk is also subtitled Wardrobe Malfunction, you can email me afterwards and I'll buy you a beer or a coffee, depending on your poison.
If you're right.
If you're right.
Right. Well, very good of you guys to join us. And it remains just to say a huge thanks to Paul. I know you are incredibly busy and it's really good of you to put this lecture in the can. And I hope lots of people will benefit from having access to it. Thank you very much. And the series will continue next week. Thank you. All the best. I'll stop recording.